Good afternoon, everybody. And thank you very much, Sandeep and Reshma, for inviting me, and thank you for the kind introduction. I thought I'd cover an overview of sleep disordered breathing and how specifically there's a role for ENT surgeon in this field. So Sandeep mentioned I've spent a lot of time at Royal National Throat Nose and Ear Hospital on Gray's Inn Road, which is now shut down. I was there for 4 years as a senior registrar and 25 years as a consultant, so nearly 3 decades at the Royal National. So sleep medicine involves a variety of disciplines, and it's generally a respiratory discipline where they deal with sleep apnea, but more and more the neurologists, the orthodontists, the ENT surgeons, the dental surgeons, the psychiatrists are all getting involved. So my role today is to talk about the sleep disordered breathing, which mainly covers snoring and obstructive sleep apnea. And it's a spectrum of disorder ranging from the simple snorers to severe obstructive sleep apnea. And this really happens because there's a turbulent airflow in the upper airway, anywhere from the nose to the larynx. So this anatomical obstruction may cause some degree of resistance. And in addition to the static obstruction, you might have some dynamic problems with redundant pharyngeal mucosa, which can also cause the obstruction. Now, if the port of entry is the nasal cavity, and if you've got nasal congestion, then you end up breathing through your mouth, and that can cause the upset dynamics of the upper airway and hence the obstruction. So Jack Burke, when he was working with me, we did this very nice paper together and emphasized the role of ENT surgeons in sleep-related breathing disorders. So what I thought I'd cover today is some aspects of diagnosis and an overview of the treatment. And obviously with the diagnosis, you want to take a good clinical history, examination, and special investigations like an ambulatory home sleep study or polysomnography. And we'll talk about the different treatment modalities. So Mark Ferguson, Jenny, and I, we wrote this Therapeutic Advances in Respiratory Disease paper where we looked at the treatment options for obstructive sleep apnea, and this is fully comprehensive. So for those of you who want to switch off now, you can just read this paper and you'll know quite a lot about sleep disordered breathing. So let's start off with history and examination. And this is usually got from the patient, but it's quite useful to have the partner present as well. And before you see the patient, it's nice to do the Epworth sleepiness score, which generally tells you about the daytime performance. So if they haven't slept well, if the sleep is fragmented, then they'll tell you that, look, I feel tired. So essentially the patients will say that, look, I feel very tired during the daytime. I can fall asleep quite easily. Sometimes some patients are very stoic and they'll carry on. And the partners will tell you that, look, I'm concerned because apart from the crescendo snoring, which is horrendous, I'm worried that he or she are not breathing very well and they stop breathing and wake up gasping. So all those things got in the history. You want to know about past medical history, if they've got any comorbidities, especially ischemic heart disease and type 2 diabetes are very important. You then want to sort of make sure that you've got their body mass index, and the high body mass index is often aggravating sleep apnea and upper airway obstruction. But over the last 3 decades, I've come to learn that what we were taught at medical school, that sleep apnea only happens in obese patients, is totally wrong. Sleep apnea can happen in a patient with body mass index of 20. So you will see this. So do not discard sleep apnea just because the patient's BMI is low. The neck collar size obviously is important, and there's literature now to suggest that neck collar size more than 17.5 will have an increase in the possibility of them developing sleep apnea. You might take their cardiovascular parameters just to make sure they're not hypertensive. And the reason for this is, if you have patients who have untreated obstructive sleep apnea, then this may result in having a higher incidence of ischemic heart disease, and hence the blood pressure might be high. They might have any form of arrhythmia. They might have type 2 diabetes. So untreated sleep apnea can lead on to lots of different things. And this would extend to things like strokes, cognitive dysfunction, and dementia as well. So during the awake assessment, you want to do the flexible endoscopy. You might want to do the Muller's maneuver. And the Muller's maneuver is basically a reversed Valsalva, and this gives you an idea as to what's happening at the nasopharynx, oropharynx, and hypopharynx. I often get them to simulate a snoring noise just to give me an idea as to how much redundant tissue there is, and that will allow you to assess whether the problem is palatal or tongue-based. However, that's not as simple as that, and for that reason, you need to combine that with other assessment methods, such as the Mallampati or the Friedman tongue position. So the Friedman tongue position is looking at oropharynx and without the tongue depressor, getting them to phonate and see how much of the oropharynx you can see. Can you see the uvula right to the top? If you look at this bottom slide here, you can see all of it with the tongue depressor, but not all of it without in the upper picture. This is again a Friedman tongue position 1, where you can see the tip of the uvula nicely and you can see almost all of the tonsil. This is Friedman tongue position 3, where you can only see the soft palate. You can't see the uvula. You can just about see the base of the uvula when you depress the tongue with the tongue depressor in the bottom slide. This is a Friedman tongue position 4, where the patient has got very limited mouth opening. And all you can see is the hard palate. Now, what this tells me is that this patient is going to be a very difficult patient from a surgical perspective. 1, because of the limited mouth opening, and 2, because it appears the tongue is quite bulky, and these are difficult patients to treat surgically. So it gives you the heads up, and you'd be aware of these patients. In terms of investigations, the GP may have done some blood tests. If the patient is feeling tired all the time, it's worth doing a full blood count to make sure they're not anemic. It's worth doing a thyroid function test to make sure they haven't got underactive thyroid. Then you may want to consider sleep studies, and this could be either an ambulatory home sleep study, which is one of the common things to do, or you might want to do a hospital-based full polysomnography if you're suspecting some underlying problems, perhaps like periodic limb movement or restless leg syndrome, or if they're getting other forms of parasomnias, then the PSG is important because it'll look at the sleep architecture in more detail. Of course, your patient may come with any of these iPhone apps, the Snore Lab or Snore Clock or Sleep Clock, and they might show you all these things beforehand, but it's still worth validating all these things with the sleep study of some form or another. And then if you decide that you want to carry out surgery for this patient, then sleep endoscopy, which is one of the things that we've done a lot at the Royal National, is something that I find quite useful in performing before we intervene surgically. So this is a slide demonstrating the home sleep study equipment. You can see the patient has nasal cannulas. They've got this strap and the pulse oximeter. They go home with this equipment and sleep with it. Not very easy to sleep with things like this, but they do. And you get something that looks like this, where you could look at the oxygen saturations, the bradytachycardias, if any, and the snoring events, as well as the positioning of the patient. Now, this isn't clearly as detailed as what a full hospital-based polysomnography would give you. And this is the data from a patient who has severe sleep apnea and a full polysomnography study. So if you look at the chart here on your left, you can see the oxygen desaturation. This is the whole night. And the marks in the red here shows this repeated oxygen desaturations. This is the crescendo snoring effect that you have. And here at the bottom is the sleep architecture, where you've got multiple arousals at the top here. And the ones in the black here is the rapid eye movement sleep. So you can see that they're not getting much REM sleep. And that is one of the reasons why they feel very tired in the morning. They feel unrefreshed. And one of the common symptoms that they'll complain about is morning headaches. And they get the morning headaches because they get CO2 retention. So that's quite common in these patients. So how do we treat them? Well, simple lifestyle changes. Again, they might have tried this and the GP might have tried it. Weight loss is useful. Reducing your alcohol intake and smoking can be useful. Alcohol is a muscle relaxant. So it relaxes the muscles of your tongue and the muscles of your pharynx in general and enhances the upper airway obstruction. And similarly, smoking will cause some degree of inflammatory changes in your nose and your pharynx. In terms of appliance, I'll cover this in a minute, and we can talk about nasal strips, the oral devices, CPAP. You might want medication. So medication-wise, allergic rhinitis can be nicely treated with medication, and that might improve the breathing and the sleep quality. And then finally, I'm going to talk about surgery and start from multi-level, minimal invasive surgery at a single level to multi-level, and radical surgery as well. So in terms of lifestyle changes, we've covered weight loss and alcohol and stop smoking, but avoid sleeping on the back. Now, there are lots of different devices and tricks that people will use. You can stitch tennis balls in the back of your nightshirt. The Germans have used rucksacks, and they sleep with a rucksack, so they don't sleep on their back. You can get various positional therapy devices, and I think I've got some slides of that as well, and I'll show you that in a minute. And in terms of non-surgical treatment for the nose, you can use the nasal sprays that I mentioned earlier on with the saline sprays, intranasal steroids, or combined steroids with antihistamine like Dymista, or indeed antihistamine tablets if you so wish to use. especially when you've got something like this with an alar collapse. You can get devices that will keep it open like nosovent. It's a clip that they just put inside the nose. Of course, if they don't like using devices, then they'll end up having an external septorhinoplasty, and which is a justified reason for doing an operation of that nature in patients with sleep disordered breathing. Or they can use a simple breathe right strips that will help them breathe better. This was the positional therapy that I spoke about earlier on. So you can see we've got all sorts of things to help them not sleep on their back, ranging from tennis ball to a bit of a rucksack there as well, and pillows that will just make you sleep on your side. Or indeed, this is from a Dutch colleague, Nico de Vries. He's got this device which is put on the neck, and it's got a sensor which will tell the device that the person's on the back, and it will make them give a little electric shock and wake them up, so you don't sleep on your back, and it habituates to you sleeping on your side. So in terms of other appliances, I'm going to cover CPAP, mandibular advancement splint. Now these are effective, and obviously they're non-invasive as far as surgery is concerned, but the compliance is somewhat poor with both CPAP and oral appliances. In most papers, it's been suggested that the compliance is no better than 50 to 60%. So, if you look at it from a surgical perspective and a surgeon's point of view, you've got 40% failure rate in CPAP, 40% failure rate in an oral appliance, then these patients should be coming to you. So when you're talking to your colleagues, and the respiratory physicians in particular, who do not like patients having surgery, you don't want to sort of tread on your toes, but you can say that, look, in your patients who fail these devices, we may be able to help you, and they can have adjunctive therapy. So the thing that patients hate most about this is that they have to use these devices night in, night out. Every single night for the rest of their lives, they have to use this device, and they would prefer a one-stop fix, and hence surgery could be a useful treatment modality. Now, CPAP, we know, is the gold standard treatment for moderate or severe obstructive sleep apnea. If you look at the NICE guidelines, it tells you categorically that moderate and severe sleep apnea patients should be given CPAP. It is, however, a cumbersome bit of device, and the compliance, as I mentioned already, is quite poor. And it's not without problems, because you're pushing in air at positive pressure. A lot of these patients will have CPAP rhinitis and aerophagia and lots of other problems which would need addressing. CPAP machine looks like this. This is the old-fashioned S6. We've now got an S10. So there's always advances in CPAP, and we're getting newer devices, every so often. These are the different types of masks. You can see this huge mask. This is a full face mask. And again, this is a slightly smaller mask. So this is a nasal mask. But the full face mask, most patients feel claustrophobic with using these devices. Here you can see the nasal mask. And there have been lots of advances in CPAP therapy all the time. We now have an auto-set CPAP, which just kicks in when the patient has got a breath-holding episode. So it's not pumping in positive pressure throughout the night. It will just activate when the patient is having an apneic episode. There are now humidifiers in these devices so that it humidifies the air so that it's comfortable to your nasal mucosa. You can get smaller masks, which is a nasal pillow mask. You can get smaller devices. And if you're traveling, you can get portable battery-operated CPAP devices as well. So here you see the patient has got a nasal pillow mask, and the device is much smaller. There's a heated humidifier. This is the nasal pillow mask. You don't have anything covering your face, just the inside of the nostrils. And the CPAP units are quite intelligent. They can work out when the pressure needs to be changed, when the pressure needs to be activated. The NICE guidelines, as I mentioned, was originally suggestive of the CPAP therapy in 2008. And I've been fortunate enough to be in the NICE guideline committee for the OSA update, which is going to be, well, it was scheduled to be out in August 2020, but because of the COVID crisis, I'm afraid it's going to be later in the year. And some of you might have seen that CPAP was in the forefront in this COVID crisis, especially at UCLH, where I think it was the McLaren or the Mercedes team that combined with the UCH scientists, and they're trying to modify CPAP as a therapeutic option for early cases of COVID, hoping not to intubate these patients, and some of them had been quite successful. So what about CPAP failures? These are the patients that we are interested in, the ENT surgeons, So do you think that if you have a patient with CPAP failure, is it because just purely about compliance? Is it young patient not wanting this for the rest of their life? or is it actually a problem with obstructive upper airway? So you want to identify exactly the root of the problem. So once again, Jag and I wrote this paper in Journal of Thoracic Diseases. When CPAP fails, what do you do? Well, we suggested referring to the ENT department for evaluation of the upper airway. And it may be that you can correct the obstructive airway so that you might not need CPAP at all, or you might partially correct the upper airway, which in turn will reduce the CPAP pressure requirement. And by doing so, it may improve the adherence and the compliance and the efficacy of the CPAP. So now moving on to oral appliance, you can get tongue retainers, or you can get mandibular advancement devices or mandibular advancement splints. You can get the boil and bite devices. You can get them made to measure. A variety of things are available. And at Royal National, we were quite fortunate having John Ruddock, our consultant anaesthetist, who had a special interest in sleep medicine, and he was doing all of the devices. But prior to that, we had help from the Royal London Hospital Orthodontic Department. And even now you've got Professor Ahmad Johal, who's done a lot of work with us in terms of research and clinical work as well. And you can do a cross referral to an orthodontist or a dental surgeon for an oral appliance. So this is a patient with an oral appliance in mouth, and this is the gold standard Rolls-Royce model, a Herbst mandibular advancement splint. Quite an expensive device, this particular one. It's a two-piece acrylic device, and it's got an adjustment here. So you can advance the lower jaw by about 4, 5, 6 millimeters, and you can adjust this. But there are lots of different devices, and I don't have any shares in this company, but this is one of the better ones to have. But when you're asking your patients to have this, you have to consider the dentition. If a patient is edentulous, then this is not a good option. And if the patient's got very poor oral hygiene and loose teeth, then it may not be suitable. You also need to make sure that you exclude your patients who have temporomandibular joint dysfunction, because advancing your mandible will have an impact on your TMJ. And so the people with TMJ dysfunction may not do well. And similarly, if you have patients who have poorly controlled epilepsy, they may not be a good candidate for this either. So this is one of my patients. The slide on your left shows that the retropalatal and retroglossal region is quite compromised. And when you've got the splint inside you can see the retropalatal region open up, the retroglossal region open up. So you see all this black hair is now more visible compared to what it is on your left-hand side of the screen. And we've done a lot of research and publication on mandibular advancement devices, and we've done sleep studies with and without, we've done sleep endoscopies with and without, and we've demonstrated it's actually a very useful thing to have. Here is a sleep study before and with a mandibular advancement splint. On your left, you have a patient whose apnea-hypopnea index is 59.9. So this is severe OSA. And I forgot to mention earlier on, the AHI, or the apnea-hypopnea index, is what tells you whether the patient is mild, moderate, or severe. So mild sleep apnea is when the AHI is between 5 and 15. The moderate sleep apnea is when the AHI is between 16 and 30. And more than 30 episodes per hour means severe sleep apnea. And this patient, as you can see, has got 59.9. And when we put the MAS inside you, the AHI drops to 0.3. Now you can tell this from the sleep study. Look at the saturations, the desaturations here, and compare them to here. Look at the snoring signal. The snoring signal is quite visible here and quite prominent, and up here it gets better. Look at the heart rate variability. You get bradytachycardias, and up here you get a few tachycardias, but not that bad. Look at the sleep architecture on the bottom frame here. You've got the rapid eye movement here, but you've got a lot of arousals. Look at all these arousals. Whereas here, the sleep architecture is much better, with the REM sleep occurring at least 3 or 4 times in that night. Whereas up here, it was only once. So these patients do better with an oral appliance. However, the side effects are still there. And you have short-term and long-term side effects. This is one of our paper we published in 2005, 15 years ago. And you can see bite changes here. These were patients who didn't actually complain of anything. But Joanna Battergel, who was working with me at that stage, was taking impressions of their teeth every so often, every year. And if they've been using it for more than 5 years, they will get a change in their bite. So is there a role for surgery? Well, having said about the devices and appliances, most definitely, I think the CPAP failures and the mandibular advancement splints would do very well from being considered for upper airway surgery if they have got upper airway obstruction. The surgery could be to correct the upper airway, or it could be to bypass the upper airway by performing a tracheotomy, which is what used to be done before CPAP came into being. And of course, if you've got a very obese patient, by performing bariatric surgery, one would perhaps get rid of many problems. If they've got metabolic syndrome, you might improve their blood pressure, the diabetes, the cholesterol, and the sleep apnea. So my surgical philosophy is to carefully evaluate and select your patients. Know which patient not to operate on, know what operation to do on which patient, and always start off with minimally invasive surgery and then move on to more radical surgery if necessary. Always bear in mind that you can combine your surgical treatment modality with a non-surgical treatment. So you might want to combine surgery with an oral appliance, or surgery and CPAP, or surgery and CPAP and appliance together if necessary. But at the end of the day, make sure that your surgery does not cause any harm to the patient. So why perform upper airway surgery? Well, in children particularly, if you see children with large tonsils and adenoids and doing an adenotonsillectomy, it completely resolves the upper airway obstruction. The results are 90% plus better. And it improves the upper airway dimensions. So in the adults, it may not work as effectively, but if you improve the upper airway dimensions adequately, then you might find that the CPAP pressure requirement in these patients, if they've got residual sleep apnea that requires CPAP, then the CPAP pressure will come down. And the key to surgical selection, in my opinion, is careful evaluation using drug-induced sleep endoscopy. And I will cover that in fair detail shortly. So we know, and it has been well documented, that the obstructive sleep apnea and snoring exhibits a multisegmental phenomenon with a significant contribution from the nasopharynx, the oropharynx, and hypopharynx. And this has been adequately confirmed by acoustic reflections, fluoroscopy, cephalometry, CT scanning, dynamic MRI imaging, sleep maze endoscopy, and pressure transducer studies using apneograph. So why evaluate in the first place? This is what is new from the 70s and 80s. In the 70s and 80s, and it was Fujita who popularized UPPP, and what they used to do, that every single patient with sleep apnea had UPPP. And that's why the results were poor, and that's why the surgeons got a bad name. But I think things have changed since the late 80s, early 90s, because we're evaluating the patients and carefully selecting our patients, we can actually offer a site-specific treatment. And that would allow you to get better surgical outcomes and also improve non-surgical outcomes. It may avoid unnecessary surgery, because if the drug-induced sleep endoscopy shows that, look, the problem is multisegmental and there's huge collapse everywhere, you're not going to correct this, then you might say, well, don't have surgery. Or if you think that the advancing the mandible during the sleep endoscopy shows an upper airway to improve, you might say, well, look, an oral appliance might work equally well as surgery, so you have a choice. So your patient then may have a choice of treatment options, and this is better for them. So here on your left is the two men in the white coats, Charles Croft and his then registrar, my predecessor, Mike Pringle. And they pioneered drug-induced sleep endoscopy. They called it sleep maze endoscopy, but now it's more popularly known as DICE, drug-induced sleep endoscopy. Prior to that, there were some Eastern Europeans working in the US who worked on natural sleep assessment, and they did this in the laboratory with the patient sleeping for 8 hours, and the scope was in situ for 8 hours, not very comfortable, but more importantly, you need to look through a video recording of 8 hours sleep. So what Charles Croft thought, well, you know, surely you can't sit there for 8 hours looking at every single patient's upper airway during sleep. So he thought a snapshot of this using drug-induced sedation may be useful. The first paper was, in fact, in 1990, and the Royal National Throat, Nose and Ear Hospital has probably got the highest number of sleep endoscopies performed in the world. So the criteria there was that you must do sleep endoscopies on patients that do not need CPAP or have failed CPAP. And the drugs we used were midazolam and propofol. And I talk about drugs because there's so much research on drug-induced sleep endoscopy now. Different types of drugs have been used, but our favorite cocktail was to use 2 or 3 milligrams of midazolam followed by boluses of propofol or target control infusion. We first published our huge series of 2,485 patients in 2007, and this was a 10-year retrospective audit study looking at nearly 2,500 patients. And I had modified the technique from the original description of Charles Croft by advancing the mandible by 4 or 5 millimeters to mimic what a mandibular advancement splint would do in these patients. So here is a chart demonstrating the different gradings, and I'll just go through the gradings very briefly for those of you who are not familiar. So grade 1 is when you just have palatal flutter and nothing else. Grade 2 is when you have palatal flutter and some degree of nasopharyngeal collapse. I'll skip to grade 5 because grade 5 is just problems with the tongue base and or epiglottis, the hypopharynx. Whereas grade 3 and grade 4 are multi-level. They can have tongue, epiglottis, palate, oropharynx, hypopharynx. So if you add up, this is single level palate. This is single level tongue base and epiglottis, and that adds up to 74%. Sorry, 24%. So 75% of your patients will have multi-level obstruction. And this is the key, because just treating one level will not be sufficient. We've also looked at the impact of the AHI on different gradings. So this is grade 1 and this is grade 5, and you can see that grade 3 and grade 4 and grade 5 have got higher AHI compared to grade 1 and grade 2. So is sleepiness endoscopy a valuable adjunct? And when Richard Hewitt was working alongside with me, he's now at Great Ormond Street, we published this data on 95 patients doing a blinded cohort study comparing awake clinical assessment versus sleepiness endoscopy findings. And we found the sleepiness endoscopy was better because actually it offered less surgery and more choice for patients. Similarly, a group in Italy, Claudio Vicini's group, Aldo Campanini, he published similar data and said if you didn't do sleep endoscopy and a sleep assessment, then you will miss a lot of pathology, and they advocated sleep endoscopy as well. What you've got to remember is that when you're assessing your patient awake, the patient is sitting in front of you, they're awake, they've got full control of your muscle tone. But during sleep, they lose control of the muscle tone, they're lying supine or on their side, so the changes in the upper airway may be significant. So that is one important thing to remember. So I'll show you some examples of drug-induced sleep endoscopy. This is just a little flutter, and you should see some vibrations of the soft palate. I hope that's projecting well, because the video doesn't seem to project well in Zoom meetings.
Unfortunately not, Vic. It's cutting out the video. I think it's just a problem with Zoom and video.
I mean, I can see it quite nicely on my screen, but it probably isn't. And here is the effect of lifting the jaw. It changes the pitch, it changes the upper airway. So you can tell your patient that, look, you can have the surgery to the palate, but you can also equally get some improvement with the mandibular advancement splint. So let's look at the multi-level obstruction. So that was a single level obstruction. Now this is a multi-level obstruction. Here you will see obstruction at the level of the nasopharynx, the oropharynx, and the hypopharynx. And you will see there's a little bit of adenoidal pads there. And as you move down, you will see the palate vibrating. And you will also see some lateral wall collapse due to large tonsils. And lower down, you will see the epiglottis is slightly retractile and almost impinging on the posterior pharyngeal wall. Here you have a epiglottic trapdoor phenomenon. Now this is interesting. This was a patient who was put on CPAP, couldn't get on with CPAP, and so let me just do a drug-induced sleep endoscopy. And what do you see? You see this negative pressure, negative intraluminal pressure, causing the epiglottis to suck in and overlie the laryngeal inlet. There's no way a patient can use a CPAP with this. So all this patient needed was a simple CO2 laser wedge resection of the epiglottis, and they didn't have any problems. They didn't need to go back on CPAP either. So some of the other work that we've done at Gray's Inn Road, this is when Humera was with us in 2012. We looked at the validation of drug-induced sleep endoscopy because people were commenting the depth of sedation is important. So we did this with the bispectral index monitoring, which looks a bit like this. You can see the transducers on the left-hand side of your screen. And on the right-hand side, you can see the BIS value here is 64. So the patient starts off with 100 when they're awake, and then they go deeper and deeper, and then you stop the sedation, and then they start waking up. And the range between 50 and 60 is a good one, so you can get 2 bites of your cherry just as they're going deep and just as they're getting waking up. So I usually look at 2 or 3 cycles of snoring, obstruction, hypoxia, breakthrough, snoring, and that gives you a good idea as to what's happening. This was one of Harry Powell's papers with me. We looked at the Elaxo stent. This is the stent, which is like a tulip shaped. This is the front part of the nose, where it would sit in the front part of the nose, and it opens up into the nasopharynx and stents the palate. So it works like a nasotracheal tube. Quite a nice thing. And we did this with the sleep endoscopy, and it's quite useful in patients who have sleepiness endoscopy grade 1. Tom Jakes and we did a paper on developing a snoring library with contact microphones. So this will tell you the severity of the snores and looking at sound frequency. We did this in conjunction with our Greek colleagues at the School of Engineering in Athens, and we found data that can be quite useful. This is a contact microphone, and we've got the BIS as well at the same time. So we did the sleep endoscopy, look at the sound analysis, and look at frequency analysis. So more recently, the Egyptian crowd have done this brilliant paper on looking at the prospective randomized study, looking at 3 different drugs. They looked at propofol, ketofol, and dexamethasone. And they did 20 patients in 3 groups, and they thought that propofol was the least safest. Now, we've used propofol and midazolam for 20 years, or more than that, 30 years nearly. But it depends on your anesthetist. It depends on the anesthetist understanding sleep physiology and careful monitoring. So basically, it is what you get used to and accustomed to. This is a clinical review paper in Sleep Medicine Review. We looked at the techniques, the gradings, and the controversies. Metlechner, when he was working with us, we did this nice clinical review. So it gives you an overview of drug-induced sleep endoscopy. And this is very much a paper that is taken into consideration the European position paper, which was a multi-central publication. So now finally, in the last 15 minutes or so, I'd like to talk about surgical treatment, and this I would divide into simple, minimally invasive, ranging up to radical treatment. And you want to look at it from a curative perspective, and if not curative, can it be a useful adjunctive therapy? You want to divide your surgery into soft tissue surgery and skeletal framework surgery. Now, there's a lot of work that is being done at the moment on phenotyping patients. And I really don't have the time to talk about phenotypes and genotypes in obstructive sleep apnea. This is fascinating work coming from Australia and America, and it's going to be very useful in sort of planning and coordinating your surgery. And this is specifically so if you get your maxillofacial surgeons to work in conjunction with you to look at the skeletal framework surgery. I'll talk a little bit about robotic surgery and just briefly touch upon upper airway neural stimulation. So this again, Priya, when she was working with me at Queen's, we did this paper on tailored surgical interventions to treat OSA. It talks about all different surgical interventions. If anybody's interested in reading that, it's quite useful to just brush up on things. So before a surgery was done for sleep apnea, tracheotomy was the gold standard. But as you can imagine, the patient acceptability with this would be relatively poor, but it would give you 100% effective results. And long-term follow-ups have been done up to 9 years. And patients who get on with it, they're absolutely fine. Now, I find that this is quite a useful option to mention to your patient. When you're seeing your patient, you tell them that you need to use CPAP. Most patients will say, well, there's no way I can use CPAP for the rest of my life. And when they say, is there an alternative? And if you desperately want them to use the CPAP, you say, yes, tracheostomy. And they'll change their mind and say, no, I'll try the CPAP first. So it's quite useful to give them that as an option. So when you correct the upper airway, you want to look at the 2 things. You know, are you just going to do a simple form of surgical intervention, or is it going to be more complex? Are you just going to work on single level or multi-level? So starting with the nose and the sinuses, adenoidal tissue, the tonsil and the palatal, or is it going to be hypopharynx, the tongue, the epiglottis, the hyoid, or is it going to be skeletal framework surgery like geniotubercle advancement or maxillomandibular advancement? Nasal surgery is done by a lot of people, and you know, this is quite useful if they've got nasal congestion, but nasal surgery, unfortunately, is terribly disappointing for snoring and for sleep apnea. You do get short-term improvements, and numerous studies that have shown that the results are not brilliant. There's some studies that have shown that quality of life parameters improve, but what is useful is this nasal surgery is very important in helping CPAP failure patients. So it will improve your CPAP compliance and efficacy, and if you correct the nasal pathology, be it a grossly deviated septum like this, or be it a gross nasal polyposis like this, you correct that and they'll use CPAP better. So this was the only proper study comparing septoplasty versus sham study. And again, one of our Greek colleagues had done this with 49 patients, but results were really poor. The improvement was only seen in 4 patients, but not adequately. The AHI was still high, so you needed to treat them with CPAP. And this is a study from Michael Friedman in Chicago. And he did nasal surgery for OSA patients just to see what happens to the CPAP requirements. And the CPAP requirement pre and post-op, as you can see on the right-hand side, in mild sleep apnea, it dropped from 7.2 to 5. In the severe sleep apnea, it dropped from 10 to 7.42 millimeters of water. And this pressure improvement was statistically significant. It improved the CPAP compliance. Similarly, the Stanford group, Camacho et al. In 2015, did a systematic review and meta-analysis. They looked at 18 studies, and they concluded that isolated nasal surgery would reduce the CPAP pressure requirement and improve the airway patency, so the compliance would be better. And we did a paper on this with the help of Peter Andrews and Jonathan Fishman. We looked at 16 studies and did a meta-analysis, and we concluded that there was a limited benefit for a small subset of patients. Moving further back into the nose, into the nasopharynx, if you've got large adenoidal tissue or any pathology blocking the nasopharynx, it's worth addressing that. Quite commonly in children, you will see large tonsils and adenoids, and it's a no-brainer. If you've got grade 3, grade 4 tonsils, you'll have a proportionate hypertrophy of the adenoidal tissue, and T's and A's would do really well. There's a lot of data on this, and this group from Oxford, Stradling's group, has shown this. Swift, ENT surgeon up north, also demonstrated this. But in adults, there are very few studies to show this. Now, palatal surgery is probably the most commonest form of surgery worldwide performed for sleep apnea patients or patients with sleep disordered breathing. It's been there since the 1920s when Trotter just did simple uvulectomy, but it was Fujita in the 70s who popularized the UPPP, uvular-palatopharyngoplasty, as we know it. But do you know what? In the last 10 years, there have been so many modifications, numerous modifications on palatal surgery. There's one by Pang and Tucker Woodson. Pang is from Singapore, Tucker Woodson is from America, and they've described this ESP, expansion sphincter palatoplasty, which before I retired last year at Grayson Road, I started doing this expansion sphincter palatoplasty, and any of my registrars listening to this, they know that we did this, and this worked quite well for lateral wall collapse. So I would do the normal laser palatoplasty, which I'm going to show you, and then I also did the expansion sphincter. Our Italian colleagues like the barbed sutures, which causes fibrosis and tightening. And there are lots of different types of lateral pharyngoplasties in the last 10 years that are coming about. But again, short-term results are there, long-term results are to be seen. Radical UPPP I have not done in 20 years because I believe that it is a nasty operation. You can end up with nasopharyngeal stenosis, you can get velopharyngeal incompetence, and you can get CPAP leaks and CPAP problems afterwards. So I don't do radical UPPP, but some people still do that. Looking at the literature, for simple snorers, UPPP can give you an improvement of anything between 45 and 80%. For the sleep apnea, anything between 30 and 70%. Now, these are wide ranges. So it depends on what people look at successes. So different studies have got different outcome measures, and long-term results are again, things that you need to look for. Now, one of the critical comments in the NICE guidelines whilst I was in the committee this year was that we do not have randomized controlled studies for surgery. So any of my young colleagues listening to this talk, you know, if you plan to specialize in snoring and sleep apnea surgery, try and devise RCTs. Now, this was one of the ones from Karolinska Institute, which has gotten to the guidelines now. And so they say that palatal surgery can be useful. And they did an objective study looking at apnea-hypopnea index. They looked at life parameters and daytime sleepiness, and have found it to be a useful treatment modality. Laser palatoplasty, again, has been around since 1980s. At Grayson Road, we started in 1993. In fact, I think the very first paper that I published on laser palatoplasty was because of Sandeep Pone being with me on the firm. And Sandeep will remember writing this paper up. So this is a patient we would have done a tonsillectomy and palatoplasty. And this is the technique that we've described. Nitesh Patel actually wrote this particular paper, but Sandeep did the first paper on the short-term results where we showed that we got something like 90% improvement at 3 months, but this dropped to 76% at 12 months. So there is a drop. And here you can see we've got swabs in the postnasal space. We're using a microscope-mounted CO2 laser. A vertical trench was performed, and the redundant posterior pillar mucosa has been excised down there. And the same thing happens on the other side. It's a relatively bloodless operation. I can tell you it is exceptionally painful procedure, and I don't see my patients for at least 3 weeks because they'll be out there to kill you because it is a painful operation. The temperature of the laser when it hits the soft palate goes up to 350 to 400 degrees C. And this is very different from the radio frequency. The radio frequency is minimally invasive. The temperature of the soft palate when the radio frequency touches it, it's about 70 to 80 degrees. So compare 80 degrees to 400 degrees. We don't stitch. The uvula is cut obliquely, so that the posterior end of the uvula is slightly longer than the anterior end, and you get a nice neouvulus stump. You can see hardly any bleeding, and when you see the patients in about 8 weeks' time, if you're lucky, you will see something like this. So you can see that the upper airway dimension is improved. So as I've explained, it's a painful operation. Short-term results were good. Our long-term results, the data for 5-year success rate was about 55%. And you can do a revision lab if you want to, but you need to repeat your sleep endoscopy to see where the problem is. And it was because of this treatment being so painful, it was one of the initiatives that we had at RNTNE to introduce radiofrequency interstitial thermotherapy within the surgical treatment modalities. And we started this with somnoplasty, and I think Guri and I did some work on somnoplasty, and we did some work with ablation. And when Taran Tatler was on there, we did some work with Ceylon. So we did work with a lot of different things. And at the moment, we're using Ceylon, which is a bipolar device. And we do multi-level radiofrequency surgery. We address different parts of the palate, and we also do the tongue at the same time. So different power settings, and this is all available from the company that does it. We also do the pro-cut palatoplasty, which means if you've got tissue to resect, you can use the radiofrequency technique to resect the tissue, and you can use the radiofrequency to perform interstitial thermotherapy as well. So these are the devices, the cutting needle and a forceps that completes your bipolar circuit. I injected some local anesthetic to give you a little bit of bulking of the tissue and give you a bit of dissection. And the needle cuts quite nicely. Again, when you cut the redundant posterior pillar, you just cut a little crescent. And once you've done that, you would then resect your uvula like you did with the laser palatoplasty, again cutting about 30% of it in an oblique manner. So once you've done that, then you use a probe like this, and that goes into the palate. So I'll show you the next slide here, the next video rather, that shows you the interstitial application in the soft palate. The trick here is to make sure that you don't do superficial. If you're superficial, you will see blanching of the soft tissue, of the soft mucosa rather, and you can get fistula. So you've got to be very careful and not to get any of the blanching. And this just goes to different levels. And once I've done the palatal applications, you will see that we'll be addressing the tongue with the same probe. So the same probe can be used for palate and tongue. And if your patient has nasal obstruction, you can do the turbinates at the same time as well. So it's really good to do multi-level radiofrequency surgery. It's minimally invasive and quite effective in selected patients. Here you can see the tongue base. You can see I've got an anesthetic laryngoscope. You can see the nasotracheal tube there. You can see the circumvallate papilla. So we don't use the laryngoscope all the time. I use a Boyle-Davis gag, and you can still see the tongue with a 30-degree scope. So this is just an MRI scan to show you the lesion in the palate and the lesion in the tongue here as well. So you can use it for soft palate, tongue base, and turbinates, and you can combine this with pillar implants if necessary. So now moving on to tongue base reduction, last 5 minutes of the talk. Very small numbers are available. This is very disappointing surgery. You can have open resection or you can have radiofrequency surgery. The tongue suspension, I've done a few of these, but found this to be really unreliable. Higher suspension, again, I'm sorry, the arrows moved from here. The studies from America showed that the AHI reduces from 46.9 to 21.3, but the dysphagia is quite great. Maxillomandibular advancement is proper skeletal framework surgery, and this is probably the most successful surgery for sleep apnea after tracheostomy. However, it's very aggressive, invasive, not without complications. Robotic surgery, Claudio Vicini has got the largest series in Italy. He's got about 500 patients now. This was 2012 data. And we started with Neil Tolley's group at St. Mary's, and Asset Aurora published this paper for us in 2015. We had long-term follow-ups in 25 patients, but altogether, I think between Neil and I, we did about 80 patients using robotic approach for CPAP failures. So here you can see the type of patients you're looking at. The MRI scan shows a very prominent tongue base with a lot of lymphoid tissue. The outcome measures, we looked at the AHI, we looked at patient-related outcome measures of quality of life, voice, and swallow score. These videos are very short. This is just a pre-op flexible nasal endoscopy that will show you what's happening at the back there. You can see a prominent tongue base and epiglottis. And this is just a arc line of a thulium laser with a robotic approach. And this is just showing further laser vaporization using a probe and one of the robotic instruments there. And this shows you what we do to the epiglottis. Again, trans-robotically, you can see the epiglottic being held by the forceps here and the thulium laser here, cutting the epiglottis. And it's relatively bloodless. You can see the swabs here in the, protecting your posterior pharyngeal wall. And we're using a Boyle-Davis guide, but you can see the tongue base and the epiglottis quite clearly in spite of that, because we use a smaller blade than what you normally would for tonsillectomy. So there you go, the epiglottis is out, and I'll show you the post-operative video at 1 month. This is running very slowly, so I'll just skip that. So AHI got better in most of the patients. The cure rate was 86%. Same with the Epworth sleepiness score, that got better over the 12 months. Same with quality of life parameters. Same with post-operative swallowing, but it is difficult for the first month. It can't swallow properly with the robotic surgery. This is the objective images of MRIs with the before and after. This is what it looks like. You can actually see the larynx. This is the patient in recovery with a proper tube in. And finally, bariatric surgery, the Royal College of Surgeons have said it's really effective for metabolic syndrome. So if you've got a patient who's got a BMI of greater than 36 with other comorbidities, they should be considered for bariatric surgery. You know, be careful with anesthesia. Pre-meds are to be avoided. Analgesia that can suppress your respiratory center should also be avoided. Make sure you've got a progressive care unit or a high dependency unit for monitoring these patients. Last 2-3 slides. What's new in sleep apnea surgery? Hypoglossal nerve stimulation. You can see in this little picture here the hypoglossal nerve, and you can see a pacemaker here in the intercostal space. There's long-term data now to suggest that hypoglossal nerve stimulation technique is useful. Unfortunately, in UK, nobody's done it yet. I was supposed to be doing it in 2019, but because of funding purposes, we couldn't do it. It is expensive, like the cochlear implants. It probably cost you between 20 and 30,000 pounds. However, this is a surgical technique to give you neuromuscular stimulation. This is what I've been involved with recently. It's an intraoral neuromuscular stimulation using a technique or a device called snoozle. This is the device. The technology is very interesting because the patient uses this inside their mouth, and this is whilst they're awake. They use this about 20-25 minutes before they go to sleep. It produces an electric current on the tongue and tones the muscles of the tongue. So it works on Bluetooth technology, and it avoids the occlusion of the larynx by toning the muscle of the tongue. The results are really encouraging for simple snorers and for mild OSA. So to conclude, ladies and gentlemen, I think there's a definitive role for ENT surgeons to deal with the upper airway surgery and upper airway obstruction. I think we're very good as ENT surgeons at evaluating upper airway, both with patient awake and asleep, using the drug-induced sleep endoscopy. If you carefully select your patients and look at the general factors like body mass index and other comorbidities to exclude who won't be good for surgery, I think you'll get good results. I think you've got to remember that it is a multidisciplinary approach, and you've got to combine your treatment, be it surgery with an oral appliance or CPAP. And I'll end with this slide, which is a didgeridoo. And there was a paper in the BMJ showing the didgeridoo can improve your pharyngeal muscle tone and can treat sleep apnea. I don't normally recommend this to my patients, but if they don't want surgery, you might want to recommend this to them. Thank you very much for your attention.
Thanks so much, Vic. Fantastic talk as ever. You've really had a journey through from when you first started, and I think I was there almost at the beginning of when you started with you as a registrar. I think Reshma's going to field the Q&As, but I just had one question before I hand over to Reshma. Sure. With all that's happening with funding and the whole process of snoring and sleep, well, perhaps not sleep apnea, but snoring disappearing out of the NHS, do you think this is going to remain as an NHS funded procedure in years to come?
I think it's dependent on which unit is negotiating with the CCG. So we've, as you know, you were at Gray's Inn Road in the 1990s, and since then till 2019, I didn't have a problem with getting authorization for any patient because we had a set protocol. We had a pathway, we had a assessment with sleep studies, and we were only operating on patients who had failed CPAP or oral appliances. It is difficult. I don't think all CCGs will listen to it, but I think there's so much evidence now to show that untreated sleep apnea is going to cost the National Health Service a lot more. So there was a paper by Stradling which suggested that if you didn't treat sleep apnea at all, the NHS would have an extra cost of £430 million annually. This was about 12, 15 years ago, and that is probably now doubled. So I think looking at it from an economical perspective and a health perspective and combining that, I think that CCGs will not have much option. But I think surgery for simple snorers is not going to be there in the NHS.
Yeah, this is what I was thinking, because certainly the CCGs where we are, which is not a million miles away from Grayson Road, have been very reluctant to do any kind of nasal surgery, let alone snoring and sleep surgery. So it'll be, I think it's going to be something that's going to be looked very closely. And I know there's been papers about that put about whether or not we should be doing these. But I agree, for sleep apnea, it may be the way around trying to do this.
So we've got a question. So with regards to the Epworth Sleepiness Scale, do you use it, and how does it alter your management? Specifically, this question is regarding if it's a low score, then do you subsequently withhold investigations?
No, I don't. I use it. I think it's quite a nice research tool, because if you got an Epworth sleepiness score before and after surgical intervention or any intervention, it's quite useful. But on its own, there's a lot of subjectivity in the score itself, because people have different opinions about, you know, how sleepy they are or would they doze off. So I think the questionnaire itself is not sufficient, but the GPs would use it. If they've got a high Epworth score of 10 or more, they would want to do a sleep study. So I think the maximum you score on the Epworth is 24, but anything more than 10 is thought to be significant. I think it's a useful thing to have, because it does give you some idea. But I have seen patients with severe sleep apnea who have an Epworth score of 3 or 4. It's just because the way they are, they just carry on, and, you know, they don't feel tired. So I think there's a lot of subjectivity. So I wouldn't rely on it entirely, but it's a good research tool.
Okay, great. So you talked about the mandibular advancement. Which patients would you choose to use it in? Is it after you perform the sleep phase endoscopy?
So look, I mean, when you see patients and if you take a clinical history and you think the patient has absolutely no history suggestive of sleep apnea, and when you've done the anatomical evaluation, you don't see anything useful there or anything that you think you may be able to correct, you might say to them that, look, a simple device like a mandibular advancement device is what you need, and they might want to try that. And they would then go to the dentist and get one orthodontist, or they can get one online. However, the way we worked at Royal National was we did sleep endoscopies on most of our patients if we're assessing for surgery. And during this assessment, we advanced the mandible by 3 or 4 millimeters, and you would see an obvious improvement in the snoring and breathing. Then we would tell them that, look, we've done the sleep endoscopy. We think it's going to be a useful tool for you. So why don't you go and spend some money with your dentist and get this a device made? And in patients who don't want surgery, it's a good alternative.
So the device that you showed, is that from a dentist?
No, that's from an orthodontist.
Orthodontist. Okay, so would you give them a specific recommendation of where to go, depending on your findings?
No, I mean, we were fortunate because we had an in-house clinician who was doing this for us. But what I would do, you know, if anybody's looking at the private sector, is to send them to a dentist who does this. So there you have dentists who have an interest in sleep medicine, and they might be able to do this for you. Now, this can be quite an expensive business, because you can get the Rolls-Royce model that can cost you up to £2,000. Now, some patients will spend the £2,000 just to find out that they have a strong gag reflex and they can't use it. So before you spend so much money, you can get simple online versions where you get the boil and bite device. Try that out first and see if you can tolerate the splint, and then spend the money.
Yeah, that's good advice. Next question is there any evidence that patients develop worse laryngopharyngeal reflux or gastroesophageal reflux due to CPAP use?
Yeah, there is some evidence, yes. And with the reflux and OSA, it works both ways, because the patients are quite obese. They have the negative intrathoracic pressure with sleep apnea, and they have the reflux coming up, because especially if they're obese, they get and they got hiatus hernia, they'll get reflux. And the reflux itself will cause edema around the interarytenoid region and will enhance and exacerbate the upper airway obstruction. So it can make the sleep apnea worse. So it works both ways.
Okay. If you're considering a palatoplasty, will you routinely perform a tonsillectomy, even if the tonsils aren't especially enlarged?
So the work we've done over the last 3 decades, we've found that if your tonsils are grade 2 or above, then it's worth doing the tonsillectomy. So 2, 3, or 4 gradings, you should do tonsillectomy and palatal surgery. If it's grade 1, then you don't need to do the tonsillectomy.
Okay, thank you. Do you always use the laser for your robotic surgery rather than monopolar?
We preferred the laser because the cutting was better. There was less charring, so we thought the laser was better.
Okay, great. Is there less obstructive sleep apnea or snoring in trumpet players and wind instruments? I think you. Is it in this?
I'm sure the didgeridoo do. And that was a study from, I think it was from Switzerland, and it was a randomized control study on didgeridoo players, and they claimed that playing the didgeridoo or the trumpet will strengthen your pharyngeal muscles. And that is, again, a new thing now. People are looking at pharyngeal muscle exercises to try and reduce that. So yes, there is some evidence, but very little.
Okay, great. And how does your sleep nasendoscopy results alter your surgical plan? I mean, I think you went through that, didn't you?
I did, because, you know, if you might in your awake assessment see somebody who's got a long, soft palate and lax, and when you do the sleep endoscopy, it might not be the cause of the problem. So the sleep endoscopy will tell you if the problem actually is the same as what it is when it's awake.
Okay, I think they're all our questions.